And
So,
thank you for volunteering to give.
welcome to our afternoon seminars. Today we have Ida Derish, a PhD student from experimental surgery under the supervisor Dr. Renzo Cirsti. Her presentation title is Preliminary Study of Patient-Specific Stem Cell-Derived Cardiomyocytes and Differences in their Responses to Hypoxic Injury, the Heart in a Dish Study. So Ida will be playing her presentation.
So hi, everyone. Thank you so much for having me here today. I'm Ida. I'm a PhD candidate in Dr. Chicheri's myocardial regeneration lab, and I'll be discussing the project that we've recently started, which is the preliminary study of patient-specific stem cell-derived cardiomyocytes and differences in their responses to hypoxic injury, which is all part of the larger Heart in a Dish study. So I'll first discuss the research context of this work, proceeding to our methodology, some exciting preliminary data that we've gathered, and I'll finish off on some future steps. So starting with some background, we're all, I hope, intimately aware of how heart failure is a leading cardiomyopathy and constitutes a leading cause of mortality and morbidity worldwide. And despite the fact that the standard of care has increased over the past few decades, there is a limited efficacy of drugs for heart failure and other chronic cardiac illnesses, and it's still very difficult to treat these conditions effectively and in the long term. There's a very poor prediction of what drug works for what type of patient. And on top of that, the administered drugs have some undesirable side effects, which in turn lowers patient compliance and reduces the drug's effectiveness in the general population. And this is really in part because during clinical trials, the diversity of the patient population is not really accounted for, and conclusions are drawn from a small homogeneous sample. Now, all of these obstacles in developing proper cardiovascular disease therapies are in part due to the fact that current models for HF and other cardiomyopathies have limited clinical applicability. So the real challenge here is, how do we personalize medical therapies for heart failure patients? Ideally, we would have a sample of patient cardiomyocytes on which to test the responses to various drugs. And here there's mainly two options when it comes to cells. The first are for heart biopsies, which are invasive for the patient and really inefficient because the cardiomyocytes which are collected are terminally differentiated, which essentially means that they do not proliferate in culture. So it would really be impossible to perform a repeatable, streamlined, and high throughput drug test. And the second option is to use immortalized cell lines, which are derived from few patients and really don't represent patient diversity. So once again, these cells might highlight cardiotoxic effects of some drugs, but most of the patient-specific reactions would be completely missed by this cardiac model. And so it really doesn't offer much value as a personalized screening tool for drug testing. Now, in 2006, a lot of the limitations that I just mentioned were resolved with the arrival of iPSCs into the picture. So these cells could be achieved by taking some somatic cells and reprogramming them. And once an iPSC population is achieved, we can modulate different pathways and factors that have already been described in the literature in order to achieve the differentiation of these iPSCs into virtually any cell of our body, including heart cells. So this really offers a wonderful, non-invasive method to obtain cardiac cells from a patient for testing purposes or for disease modeling and so on. Now, before we move on to the preliminary data that we have already collected, I would like to quickly walk you through our process. So we received the patient blood and we proceed to the isolation of PBMCs, which are a subset of blood cells. And then we select further for CD34 cells, which are reprogrammable via electroporation. And we actually use episomal vectors, which consist of a slight variation on the classic Yamanaka factors. And even though the success rate is fairly low, so at 0.07, 0.03%, these cells eventually adhere to the plate. And once that step is done, the cells are officially stem cells. So you can see in the circle, they have a very stem cell-like appearance. And our job is from there on to achieve a pure population. So we kind of cut them out and continue purifying them and morphologically assessing them to a pure population. And then we're ready to actually proceed to the differentiation protocol for our cardiac cells, which you can see there. And you can see that this is a protocol that takes around 2 months before we're able to achieve a cardiac-like cell at the minimum. So how do we make sure that our cells are of high quality and high purity? Well, the first step towards determining this cell quality is during the stage where we produce the stem cells. So for each sample and cell line that we produce, we actually perform immunofluorescence staining of nuclear pluripotency markers, such as OCT4 and NANOG right here, as well as surface pluripotency markers such as SSEA4 and TRA160. And this is in fact the golden standard for most commercialized iPSC lines. And of course, once we generate our iPSC-CMs, we make sure to stain them both for the cardiac markers to confirm that they're cardiomyocytes, as you can see, right here. And we also stain them with pluripotency markers to confirm that there are no longer any stem cells in culture. And you can see here that there is virtually no staining there, which is a good sign for our cardiac cell population. So far with the Heart in a Dish study, we have established a biorepository bank in our lab that currently holds over 100 blood-derived patient samples. But for today's presentation, I'll really be focusing on 3 cardiac lines that we generated and for which we gathered some data. And the different experiments that we have performed relate to contractility over time, to the metabolic activity in response to hypoxic injury, and protein expression in response to hypoxic injury. So here you go, a video, which is probably the most exciting thing that I have kind of seen in a long time while doing science, of one of our iPSC-CM lines. And I'm happy to say that all of our lines that we've achieved through this process, we're able to start beating, albeit to different degrees. And I'd like to kind of bring your attention to the way the contraction kind of progresses from the bottom upwards, kind of propagating. And it gives a sense that these produced cultures have beating synchrony. Now, our first step was to kind of assess contractility over time in a healthy donor and cardiomyopathy patients. And the idea is that during the differentiation process, iPSC-CMs start beating when they differentiate, and eventually the beating slows down. So here we took a minimum of 5 videos a day for each cell line and counted the beats over the course of 20 days. And we can see here that for the control patient, the plateau kind of happens around day 8, which is consistent with the literature. However, for patient CM1, the plateau actually occurs much later. And then finally, for CM2, the plateau is never achieved and the beating just seems to be more and more erratic as time goes on. So already here we can see differences even at a baseline without any kinds of injury or treatment. So now that we've done that, we actually subjected the iPSC-CM lines to 24 hours of hypoxia and serum-free media. And here we can see that in the control, surprisingly enough, metabolic activity was increased, which could be a stress response. However, in both the cardiomyopathy patients, the metabolic activity either stayed the same or was reduced when compared to normoxia. And while this is preliminary data, this still kind of indicates or points towards the fact that the cells coming from different patients might respond differently to injury. And it'll be interesting to see if this is mirrored in the patients themselves. And finally, we looked at protein expressions in the iPSC-CMs under normoxic and hypoxic conditions. And on the left, you can see the different cardiac markers, which were all expressed in the iPSC-CM cultures. And you can see that in some, such as sarcomeric alpha-actinin, SERCA2A, GATA4, and connexin 43, they seem to be more strongly expressed in the hypoxic injured cells, which is interesting. And could point towards some things that I can discuss in the question period if you're interested. And we also actually started looking at other markers, specifically some kinases that play essential roles in cardiovascular disease, and specifically the protein kinase C, PKC, which studies have shown is expressed highly in neonatal hearts as well as in heart failure, but have decreased expression in adult and healthy heart cells, which you can see right here. And PKC is also responsible for inducing gene expression or by activating the mitogen activated protein kinases MAPK right here. And what we see here is very interesting in my opinion. While the control right here has low expressions of PKC regardless of whether it's in normoxic or hypoxic conditions, the injured cardiomyopathy patient lines expressed high levels of PKC in response to the injury. And it's been suggested that inhibition of different PKC isoforms should be a target for drug development to prevent irreversible cardiac injury during ischemic reperfusion in humans. So this is kind of an interesting result that I think we should kind of investigate further. So overall, as a summary, I hope that you saw through our preliminary data that at the baseline, generated iPSCCMs display different beating patterns, that upon hypoxic injury, iPSCCMs may display differences in metabolic activity and protein expression, that the study of patient-specific iPSCCMs provides insights on differences between healthy controls and cardiomyopathic patients. And of course, the future steps, the main future step is that a larger population of iPSCCMs should be studied in order to draw any kind of significant conclusions, whether it be related to the disease state or perhaps sex differences and other differences that are very interesting to study in the context of personalized medicine. So I would like to thank my supervisor, Dr. Chicheri, who's the principal investigator of our laboratory. And these are all the people in my lab who have helped me tremendously in this work and that will continue working on this project with me. So thank you to everyone involved. And I have no disclosures, and I'd like to state that this research was funded through the Courtois Cardiovascular Signature Program, which is trying to pave the way for truly personalized cardiology at the MUHC. So thank you so much for having me, and I will welcome any questions that you might have.
Thank you, Ida, for the presentation. It was really interesting to see your study. If there's any questions, please feel free to unmute yourself and ask Ida her questions.
Can I ask you a question, Ida?
Yes, please.
So I'm sorry, I missed the beginning, so I had to fill in some gaps. But if I understand, you're saying that patient-induced cardiomyocytes can be used as a kind of in vitro surrogate to stratify different responses to ischemia amongst patient population, right? Is that right?
Yeah, that's exactly it, yeah.
So my question is then, you're going to get a range, right? You're going to get some people that reasonably resistant to it and some people that aren't. First question is, what's the extent of the range? Is it clinically meaningful if these cells display a bit of a difference in culture?
Yeah, so that's actually a really good question that I don't necessarily have an answer for. And I think I'll only get that answer once we have sufficient samples to really test it on. I think one of the things that would be interesting to do is to kind of start testing drugs on these cells, looking at different reactions and then correlating it potentially to the information that we have on these patients. So we're pretty lucky we're having a collaboration with Dr. Giannetti, who has information on all of these patients, has information on all of the drugs that these patients have taken and the outcomes. So looking to using these drugs on these cells and seeing if there is any correlation in the first place. Because if, let's say, we find that there is no correlation, which would be incredibly disappointing, and I personally do not believe that will be the case. But if that occurs, then we'll see that this is not an appropriate model. However, if we do see a correlation, that'll kind of invite us towards examining other therapies and then studying them in these patients as well. I don't know if that answers the question. It's kind of wishy-washy for the moment, but
let me try coming at you from a different direction. Can you give us an example of a cardiac therapy for, cardiac ischemia that works brilliantly in some patients and even has a detrimental effect in others?
Yeah, it's a very good question, which I have not prepared for. But
just to get, I mean, there must be, right? There must be some drugs that work better for some reason in some people. I mean, that's the nature of drugs. So
well,
I just wondered if you had a target therapy in mind that.
I know for, we're going to have another project kind of in parallel, and I'm maybe a little bit more familiar with that. I know some angiotensin kind of inhibitors, those kinds of drugs, they're known to work quite well in some patients. I think it's something like 30% of patients, it works quite well. I don't remember off the top of my head, but around 30 patients, it works quite well. And then in other patients, it really has no effect. And then in other patients, it could take months of discomfort and like secondary effects I'm not quite familiar with, but I know there are some secondary side effects to these drugs, and they spend months without any kind of benefit to their actual like cardiac health.
Sounds like a good answer to me. So thanks very much. That's very interesting. Thank you.
Thank you.
So Ida, very interesting work. I like that function of the just some basic questions. So when you compare the IPS derived with just the primary cardiac cells, because you said that beating tails off, do you know if they are identical in terms of function?
I would say, so we haven't tested the function yet, but I can talk from a morphological perspective because we've started looking at them more like from a morphological perspective. The cells that we actually achieve are quite kind of fetal in phenotype. So the difference between the cardiomyocytes that are achieved from iPSC CMs and cardiomyocytes that are in primary cultures is that these are quite elongated. Sometimes they have a lot of nuclei, and that's kind of a telltale sign that they're quite mature. But in iPSC-CMs, they're more round-like. They look more kind of like footballs, and they have only one nuclei. And they express some markers as well that are more fetal and embryonic in nature. So you can tell that they're less mature. So that's one kind of main barrier in studying iPSC model and like implementing iPSC-CMs as a model for cardiac disease is that they're not as mature. However, that's something that we can work on as well. And I know a lot of other groups are working on developing strategies to make the cells more mature. So, and that kind of reflects, again, in the morphological, they kind of go from these circular kind of small cells expressing cardiac markers, but also embryonic cardiac markers towards expressing kind of an adult phenotype.
Yeah, that's wonderful, Ida. Wonderful project.
Thank you.
Hi, Ida. Wonderful talk. I just have a general question, actually. It's probably my naivety on the iPSCs. So we have this similar problem when we differentiate bone marrow MSCs. And I was just wondering if the donor age has any effect on the development, the passaging, and the differentiation of the iPSCs. And if so, will you be limiting your patient pool when you're doing the study?
So from what I've read, no, there should not be any kinds of limitations. But from my experience, again, my sample size is way too small to have any conclusions drawn from it. However, the passage number does matter. I know that if you try to differentiate it when it's too early of a passage, it might actually have it might actually still, like in my case, it might still have some episomal vectors within the cells, which might impact the differentiation process later on. And if you passage them too late, they might have, and I'm talking too late, like P60, P30, okay. P60, something like that. If you passage it too late, these cells acquire some mutations, as you kind of expand these populations. So that might also have an effect on your differentiation process. But if you kind of hit that really nice spot of, P10 to P15, even sometimes P7 to P15, I think it works quite well. Yeah. Again, that's to my kind of still fairly novice, outlook on this whole project.
Sure, it's more experience than I have, so thank you.
So I think if there are no further questions, Ida, really wonderful work.
Thank you.
Please don't forget to fill up the evaluation form. It's in the chat. Mike, yours.
Sure. So I have the pleasure of introducing our next speaker, Dr. Prakash, who is a breast surgical oncologist and assistant professor of surgery and oncology at McGill University. Just a brief background on Dr. Prakash. She has completed a general surgery residency training at McGill. Afterwards, she went on to complete a master's degree in health policy and financing at the London School of Economics and the London School of Hygiene and Tropical Medicine. After her training there and her master's degree there, she went on to complete. She went on further with her medical degree and did a fellowship in breast surgical oncology at Duke University in Durham, North Carolina. During her fellowship is where she developed her expertise and interest in health services, and particularly in breast cancer patients. She then came back to McGill University to continue her practice and research on the financial toxicity in women with breast cancer in Canada. So I'd like to welcome her and the title of our talk today, which will be Financial Toxicity Related to Breast Cancer Care in Canada, Exploring the Cracks in Our Universal Healthcare System.
Thank you very much for that introduction. I hope everyone can hear me. Just a few disclaimers. So the title of my talk has changed slightly. I'm going to be giving an overview of financial toxicity in cancer in general, and not just breast cancer. And we're going to look at the US experience as compared to the Canadian experience as well. And the other more practical disclaimer is that I am on call and have been all week. So I apologize in advance if I have to run off. I'm on call for general surgery, so we can have some emergencies which require rapid attention at times, but hopefully not. It's 1 p.m. and things seem to be okay in the afternoon. So with that, let me share my screen. Are you all seeing this as the presenter view?
Yes, Dr. Prakash, if you want, on the top left of your screen,
Yes.
the second icon, click on it and then click on swap. Sorry, the last one, the third one. There you go. Thank you.
Would you be able to help me how can I see my own presenter view?
If you have a second screen, yes, you have to put it into your other screen, or else, if it's okay for everybody, then you should show it into that mode that you had before. How do you feel?
I think it's a glitch of Zoom that you can't do that.
So how you feel better, like this or more with the presenter?
I'll use the presenter view, as I don't think I have all my mental capacities with me. I don't think I've slept in 5 days, but.
Excellent. So yes, so then go back to the other view. I think it's down left.
Oh. Nothing's happening.
Or else press escape.
Let's see. Okay.
And there you go. Go back to your.
The joys of Zoom. Okay, so please try to ignore my notes, which I'll be reading. Okay, so I'm very honored and excited to present on this topic that's near and dear to my heart. So financial toxicity in cancer patients, lessons that we can learn from the US and the cracks in our own universal health system. Like Michael said, I trained in Canada, did my general surgery residency here, and really, cost to patients was not even a consideration usually for us in training. I was always interested in global health, and access to care was always part of my research interests, even throughout residency. But really, when I went to fellowship, did I realize how important cost of care is as a barrier to access and as a barrier to getting the good quality care that our patients deserve. I was at Duke University, which I'm going to go through a few studies, and you'll see that Duke is really where the term financial toxicity was coined. So perhaps I was influenced quite a bit by them in choosing my research focus, but it's starting to, well, I shouldn't say starting, the research started in the early 2010s, and really it's picked up steam in the US. And it's been very well characterized in cancer patients in the States. And we're only just starting to learn about it here in Canada, that even in our universal healthcare system, yes, we could have patients who are suffering from financial toxicity. So I have no financial disclosures for my research. So really, what's the definition of financial toxicity? Dr. Youssef Zafar is the one who coined the term, and he called it financial hardship and impact of cancer costs on the well-being of cancer patients. So really what they were trying to do was to draw parallels between the physical toxicities of cancer therapies like cardiotoxicity, nephrotoxicity, and the cost-related toxicities of therapy as well. This is the definition from the National Cancer Institute. So the NCI calls financial toxicity something that describes how out-of-pocket costs can cause financial problems for a patient. And they comment that cancer survivors usually report higher out-of-pocket spending than people who have not had cancer. I personally find this definition, this NCI definition, very narrow. I think there's a lot missing here, including indirect costs to patients, so costs of lost wages, which are a significant proportion of financial toxicity, cost to caregivers, and cost to society as well. So this is an opinion piece that was published in the New England Journal of Medicine in 2013. And it really was a call to arms to include out-of-pocket costs as side effects of cancer treatment. So Dr. Ubel, who's a physician and a health economist who's written quite a few books on health economics, and Dr. Zafar's group really advocate for having conversations with patients in clinic, just as you would talk to them about side effects of any cancer treatment that you were going to recommend to them. Just in the same way, out-of-pocket costs should also be developed, because otherwise we risk missing patients who will suffer from financial toxicity. So I feel like I've been saying the word financial toxicity a lot, and we've been talking about it already, but really, how is it defined in economic terms? What is the burden of financial toxicity in the US? So in the recent article, Gilligan et al. Reported on financial toxicity in patients who were diagnosed with cancer, where they looked at the change in net worth of a patient at 2 years after their diagnosis of cancer and at 4 years after their diagnosis of cancer. They characterized financial toxicity in 9.5 million newly diagnosed cancer patients over the age of 50 between 2000 and 2012. And they reported that the average net worth at the second year after diagnosis, it decreased by over $92,000. So that's astronomical. And over 42% of patients fully depleted their assets, and over 30% incurred some sort of debt, as you can see here, either consumer or mortgage or home equity by the second year of their diagnosis. They found that the odds of net worth depletion were higher for patients who had worsening cancer, so progression of disease, and for those with public and of course no insurance, they were hit harder. So one of the big limitations of this study is that it was done in an older patient population. They only included patients 50 and over. And by doing so, you exclude the part of the population who's potentially going to be more at risk of financial toxicity. As you know, when you're younger, that's when you may have a young family, you may have kids who you need to save for school for, or a mortgage or car loans, and things like that. So, and also there are the most economically active part of the population. So the societal costs to losing that part of the population out of the workforce is also greater. So this was a study that was actually published a long time ago in 2002, which looked at the change in average annual income 5 years post-diagnosis. So we know that cancer patients are really more affected by income loss than non-cancer patients, and that makes sense. Cancer is a long-term diagnosis. It's something that requires multiple visits to your doctor, potentially multiple surgeries, radiation, chemotherapy, and these are longitudinal treatments. It's not a one-shot, you're in, you're out, it's an appendectomy, you're done. And it requires potentially long time off work or changing from a full-time to a part-time position, so it makes sense that cancer patients are more affected. So this was a breast cancer population. And once again, these findings sort of tell us that that cancer exacts an economic toll from long-term survivors. So you can see that in cancer patients, the change in average annual income was a decrease of about just over $3,500 compared to control subjects who saw an increase in their annual income of about $1,800. The other interesting part of this study was that they saw that changes in total household earnings were also lower for survivors, suggesting that cancer doesn't just affect the individual who's been diagnosed, it affects entire families and caregivers. We also know that unfortunately in the US, a cancer diagnosis is associated with a significant risk of going bankrupt. So this was a study in 2013 that looked at 200,000 bankruptcy claims. And they found that patients with a cancer or individuals with a cancer diagnosis were at 2.65 times an increased risk of declaring bankruptcy. And younger cancer patients, so cancer patients under 65, were between 2 and 5 times more likely to declare bankruptcy than their older counterparts. So we're already getting signals now that financial toxicity is a real burden for patients. It affects younger patients. And this is a study that looked specifically at that. It examined 1,200 patients from the Medical Expenditure Panel survey that was administered by the Agency for Healthcare Research and Quality. And the authors examined both material and psychological financial hardship. And then they stratified by age. So material financial hardship was defined as, lost income, whether patients took on additional debt to pay for their treatment, and so on. And the two age groups that they divided into were age 65 and over, which coincides with when Medicare would cover someone, and ages 18 to 64. And what they found was that, as we thought, financial hardship is inversely proportional to age. Among the younger population, so the 18 to 64-year-olds, 28.4, so just under 30% experienced material financial hardship or objective financial hardship, and 31.9 experienced psychological financial hardship. And making this difference between objective and subjective, or material and psychological, is important, and we'll see why shortly. So this is the seminal paper by Dr. Zafar, where the term financial toxicity was first coined in 2013. Dr. Zafar and his team conducted an observational study of self-reported treatment-related costs and subjective financial burden among insured patients with cancer seeking co-payment assistance. So the important thing here is that, it's easy for us to say, okay, well, here in Canada, we have public insurance, everyone is insured. So, why do we care about this? We know that uninsurance is a huge problem in the US, but this study was specifically looking at insured patients who were seeking co-payment assistance. And they then compared this group to their so-called control group, who were cancer patients that were referred to Duke University Cancer Center. And those served as a financial low-risk control arm, or patients who did not seek co-payment assistance. 254 patients were included in the analysis. And so excluding indirect costs, okay, so only out-of-pocket costs, the median total out-of-pocket costs on cancer care-related expenses was $456 a month. And just keep in mind, $456 a month may not sound like a lot for a lot of people, but the majority of these included patients had annual incomes of less than $40,000. So this figure translates to about 15% of their annual income that was spent on just out-of-pocket cancer costs. And we're not even talking about the indirect lost wages. So if you look at the subjective financial burden now, they found that about 42% of patients reported either a significant or a catastrophic financial burden. This is looking at the forest plot. You can see that amongst the variables, the ones that have found to have a statistically significant association are age older than 65, a smaller household, and not applying for co-payment assistance were associated with lower subjective financial burden, whereas communicating with your doctor about costs was associated with a higher financial burden. I mean, the confidence interval is wide, but it gives us a signal that, and it makes sense. I mean, if you're more worried about your finances, maybe you'll be more inclined to communicate with your healthcare provider about them. What's really interesting in this study and what's very important is that the percent of income that was spent in out-of-pocket costs between the two comparison groups was not statistically significantly different. This means that objectively calculating out-of-pocket costs was not completely adequate enough to study the real burden of financial toxicity, because as you can see here, in those that applied for co-payment assistance, they were found to have a higher financial burden. So patient-reported outcomes matter, subjective financial toxicity matters, and we'll get to that shortly. So to sum up, cancer has an objective or material and subjective or psychological financial toxicity, both of which can be measured and have been done over and over again. I mean, this was just a few studies. There have been countless looking at different types of cancer patient population, different treatment modalities. So, financial toxicity in patients who undergo radiation therapy, for example, versus those who are undergoing surgery for cancer. And we've also seen that it tends to affect younger and more economically productive patients. So why does it matter? I mean, you could say, listen, you're a doctor, why do you care? I mean, someone else should be taking care of this. Why does it matter to you as an oncologist? So we know that financial toxicity is associated with decreased quality of life. This is data from the ASCO 2019 Cancer Opinion Survey, which they run every year with different themes. And in 2019, they found that treatment, over 50% of patients had treatment affordability concerns, and they had kind of remained stagnant since 2017. So for the last 2 years since the survey. They also found that not only do finances cause anxiety in the majority of cancer patients, but they also cause anxiety in the majority of caregivers and in a large proportion of family members or loved ones. There was another result from the 2018 survey, which I haven't put up, but it was quite striking. And it showed that more patients, not by much, but more cancer patients were worried about the costs of their cancer care than were worried about dying from their cancer diagnosis. And it was in the range, it was just about the 50% mark, which to me was shocking. We also know that financial toxicity may present as an obstacle to treatment or even to preventative care. So high treatment costs, including out-of-pocket medication costs, have been linked to lower adherence to cancer treatment. And delaying or foregoing care can have drastic consequences for patients who are undergoing cancer treatments, resulting in less effective treatment and shorter survival. And of course, that's something as a surgical oncologist, I care a lot about in my patients. Delaying or foregoing care can also affect surveillance for disease recurrence. So for me, for example, my patients getting mammograms might be impacted, screening for second cancer, and care for late and long-term effects of cancer treatment. Oops, sorry. So there was this study that was published in Cancer in 2013, examined the relationship between financial toxicity and delaying or foregoing cancer care using national survey data. And after adjustment, participants who reported a financial hardship were almost 2.5 times more likely to delay their care and over 2.5 times more likely to forego their care completely. And in absolute terms, they found that up to 13.5% of cancer patients were foregoing cancer care completely because of cost. So again, we know that now we know that cancer patients may delay or forgo care. And we also know that cancer patients may forgo medication or not adhere to medication as prescribed. So that's one way how patients forgo or change cancer care around cost decisions. So this study found that there were a couple of studies that looked at that actually, and they found that up to 27% of patients used medication non-adherence as a mechanism to protect themselves against financial toxicity. And what that looked like was either they would not fill out prescriptions, or they would fill out part of the prescriptions, or they would take less than the recommended amount, or they were skipping doses to make medications last longer. And then ultimately, financial toxicity has been linked to increased mortality. So in this study of over 200,000 patients with cancer, where they linked SEER registry data to federal bankruptcy claims, they showed that cancer patients who filed for bankruptcy were almost 80% more likely to die than those who did not. And most interestingly, because you may ask the question, well, what stage were they? When they excluded patients with late stage disease from the model, it did not affect these results. So cancer affects your finances, which then affects your cancer. And a lot of patients are stuck in this loop and have a hard time getting out of it. And the thing is, with the impact that it has, not just on the patients, as we saw, but also on caregivers and on families. You know, if you have a patient that dies from their cancer, well, the family is still left reeling and trying to deal with debts. So why is this happening? You know, drivers of financial toxicity, of course, are a product of the geopolitical context and the healthcare system context. So I'm going to talk about the US. Financial toxicity is multifactorial, so it has multiple different drivers. And I think, and a lot of people agree, that the biggest contributor most likely is just the fact that healthcare is really, really expensive nowadays. This is a graph that I found very striking, and I've put it up even though the data is old now. This is from 2011, and now the latest projections, I do believe we have projections going to 2028 now for national healthcare spending. But I really like this chart because it shows the complete dissociation between the economy as a whole, which you can see as your GDP here between 1960 and 2010, and the healthcare sector, which is just skyrocketed. So annual health expenditure in the US went from just under $75 billion in 1970 to over $3 trillion in 2015, and is set to exceed $5 trillion in the next 5 years. I mean, I don't even know how many zeros that is. I mean, $5 trillion, that's larger than like a lot of the world economies combined, you know, and that's what one country spends on its healthcare. Compared to that, wages have remained absolutely stagnant, as you can see, and that is a whole other issue. But you do see that this is not sustainable. By far, the biggest driver of the rising costs of cancer care are the gigantic costs of anti-cancer drugs. So oncology drugs account for the largest spending of any specialty in terms of pharmaceuticals, and patients in the US account for nearly half of the global anti-cancer drug market. So this chart shows you the exponential increase in oncology drug costs in the US compared to, once again, the absolutely flat income curve here. And here where they've shot up, I'm not sure what happened. Maybe some of you on the meeting might know what happened in 95, 99, but I didn't get a chance to look it up, but clearly it's been an exponential increase. A lot of people speculate, why this is, research and development, it costs a lot of money to come up with cancer cures, of course. I just threw this in as a cheeky little graph. You really can follow the profits. So here it shows the percentage of total spending on hospital care versus prescription drugs, and then the profit margin of prescription drugs versus hospital care. So, R&D might be a component, but it's certainly not the only one, and maybe not even the biggest one. So what happens? I mean, are insurance companies just going to absorb these costs and say no problem? Of course not. So one of the other drivers is increasing cost sharing mechanisms, and the way insurance companies deal with these skyrocketing costs are that they shift a greater proportion of the expenses to patients in the form of increased deductibles or higher co-pays and restrictions in specialty medication plans or coverage gaps. So we know that healthcare costs are increasing and insurance companies are shifting the burden onto patients, but we are also just treating more than we ever have. We're treating more cancer than we ever have in the history of human medicine before. So there are more people being diagnosed with and treated for cancer than ever before, with perhaps only a marginal improvement in survival now, if any at all. And again, it's multifactorial, like everything in medicine, but the implementation of screening programs has inevitably led to earlier detection, which is great, even at the pre-cancer stage for some diseases, also great. But the pendulum seems to have swung a little bit too far when it comes to treating very low risk or very indolent tumors. So tumors that may not have ever become symptomatic and certainly not affected someone's survival. So for example, we know that watchful waiting is a very valid treatment plan or surveillance plan for low risk prostate cancer. We also know that there are three multinational trials currently ongoing looking at de-escalation of therapy in ductal carcinoma in situ, or DCIS. And those trials, funnily enough, have had a really, really hard time recruiting patients. And why is that? Well, because as soon as you say the word cancer to someone, that's it. It's really hard for someone to choose active surveillance or watchful waiting over surgery when they hear that they have cancer. We live in an information age. We're bombarded all around us with stories about cancer survivors, how patients with stage 4 cancer are living longer, and bilateral mastectomies for breast cancer, and so it's really hard. And I completely get that. If I were in that position, I would want it out of me too, So it's a really hard thing to de-escalate care once we've escalated it so far. Oh, I thought I had a slide. I think it accidentally got deleted. Basically, we talked about overtreatment and early diagnosis, so overtreatment of low risk or pre-cancer. But then at the other end of the spectrum, we also have overtreatment at the end of life stage. We're also spending a lot of money on cancer patients in their last, few months of life on chemotherapy and ICU, and not really concentrating on quality of care. And all of that has costs. Nothing, nothing is for free. So what are some of the solutions? Any complex problem, a viable solution to financial toxicity needs to take into account the implicated stakeholders, which go from government and policymakers to healthcare systems and healthcare providers, and then to individual patients and the individual patient-provider relationship. So I'm not going to go into the details of policy interventions in the US, as that's above my pay grade. But needless to say that policy interventions are dependent on the political context. And that means that, policy interventions that would work in the US, such as Medicare for All, Obamacare, which helped a lot with financial toxicity, may not necessarily be relevant for our Canadian context. If you think about financial toxicity as a public health problem, I thought this was a good way to think about it. There's the prevention pyramid in public health, which talks about primary prevention, which aims to prevent disease or injury before it ever occurs. Secondary prevention, which aims to reduce the impact of a disease or injury that has already occurred. And tertiary prevention, which aims to soften the impact of an ongoing illness or injury. So how do you help people live with it? The solutions, now this is by no means an exhaustive list, but it's a broad stroke of certain sort of overarching solutions that could help in either of the prevention categories. So if you go top down, we have the de-escalation research and the value-based care research, which are ongoing. And at McGill, we know a lot about this, and I don't have to preach to the choir. It's a question of really implementing this at the policy level and into practice. So, things like the American Society of Clinical Oncology choosing wisely guidelines, which really put value into the center of cancer care discussions and cancer care decisions, Then you have health technology assessment and comparative effectiveness research with agencies like CADIS at the Canadian federal level and INES at the Quebec level. We are actually, doing this a lot more than our neighbors to the south. So I am very proud of this. And then if you go into more grassroots level, so you need education, both for patients and providers into the concept of financial toxicity. Just giving it a name actually helps, and how to have conversations and how to open the dialogue about it, because it turns out that a lot of patients do want to talk about it. We just don't know how. So we know that at least in the US, patients want to have these cost of care conversations. And there are studies that suggest that physicians are interested in discussing costs, but very few feel comfortable or prepared to have that discussion. But just simply opening the lines of communication and asking, hey, are you having any issues with your finances? Can be a really important means to ally yourself with a patient. And many patients, on the other hand, also want to reach out, but they don't really know how to broach the subject with their, treating physician in clinic. It may be a very awkward conversation, and it's also very cultural. So just over half of patients surveyed in this study wanted to have discussions surrounding the burden of the financial burden of their cancer care with their oncologist, but only 19% had talked to their doctors about it. And when they asked these patients, well, why didn't you just bring it up? Very interestingly, they found that 28% did not talk about costs because they wanted the best care regardless of cost. So there is this concern in patients, at least in the US, that they may receive lesser quality care if they bring up costs with their oncologist. But we've seen that that's not necessarily true. And in most cases, you can actually help reduce the financial burden without changing the treatment plan. So of the 19% in that study who had talked to their doctors about costs, the majority, so just under 60%, reported lower out-of-pocket costs. And importantly, most of these costs were reduced without changing treatments. So how they did that was, by decreasing frequency of doctor's visits, by decreasing the number of tests perhaps, and really, implementing those high value research findings. And maybe you don't need to do PET scans every 2-3 months, switching to less expensive medication, facilitating insurance approval. So just advocating on your patient's behalf with the insurance companies, and referral to a financial assistance program. This was another study where patients were surveyed in a gynecologic cancer clinic, which was affiliated with an academic private clinic affiliated with the university healthcare system. And patients were asked, well, what would improve, what interventions could help them mitigate the financial toxicity that they felt secondary to their cancer care. And you got a whole bunch of different responses, but these were the most common, and this was 87 patients, so it's a rather small study, but it's still interesting. Most patients said that transportation assistance, very important, often simple to do. Knowing costs ahead of time, minimizing wait times, and access to free food would be most helpful. So again, these are not very complicated things. It may require additional time on the part of the oncologist. It may require setting up a system in clinic, which includes financial navigators. But keeping the lines of communication open could really be the simplest way to determine how a patient's financial toxicity can be addressed. Simple and cheap. So Canada, when I went to the States, it was definitely a culture shock in terms of the healthcare system. And I was so proud of being from Canada. And, I was going to go back there, start my position, and we wouldn't have to see these patients suffering from financial toxicity. And so imagine my surprise when I start my practice at the Jewish General Hospital, and one of the most consistent questions I get is, related to financial burden. And I'm fairly certain that that's because we serve a very diverse population, including a very largely immigrant population and refugee population. So there are a lot of concerns surrounding that. But it kind of gave me a signal that, this might be a reality for our patients too. It's not just, it's easy to say, oh, those people south of the border, they don't have a free healthcare system. We have universal healthcare coverage, but do we really? And if we do, why are patients suffering? So the Canada Health Act, which was established in the 80s, aimed to provide universal healthcare coverage for all Canadians. And I really liked this quote. It's from Senator Jacques Hébert during one of the debates on the enactment of the Canada Health Act. And he said, I'm going to read it to you. He said, thanks to Medicare, no one need worry about any financial burden resulting from an unforeseen illness. This program is not only for the young, the wealthy, and the healthy. It is designed also to help the poor, the old, and the chronically ill. Very, very laudable. So the aim of the Canada Health Act is to ensure that all eligible residents of Canadian provinces and territories have reasonable access to medically necessary hospital, physician, and surgical dental services that require hospital setting on a prepaid basis, so that's important, and without charges related to the provision of insured healthcare services. So no admin charges, no administrative fees. Yet, there is no ambulatory drug coverage for 18 to 64-year-olds in 7 out of 10 provinces. There are monthly limits on home care, very pertinent for cancer patients or chronically ill patients. There are monthly limit on allied health professional visits, example, physiotherapy, which I learned very quickly by my patients telling me that when I refer them to the physiotherapist for their lymphedema, only the first visit or the first 2 visits are covered, and what are they supposed to do? There are monthly limits on medical supplies, same thing. Certain diagnostic tests and procedures are not funded by provincial plans. Out-of-pocket payments are still required for travel, parking, and so this is a problem even in our system. Longo, Chris Longo et al. At McMaster, we're really doing a lot of work related to financial toxicity in cancer in general, and specifically in universal healthcare systems. They did a Canadian study where they surveyed over 900 cancer patients across 20 healthcare centers in Canada, and found that about a third experienced high levels of financial burden, and about 41% made some sort of financial sacrifice to be able to pay for their cancer care. So just looking at those numbers, I mean, to me, what stands out is that they're not that different from the US. So we really need to look at what's going on in Canada, and is our universal healthcare system really universal? Ultimately, they estimated that Canadian cancer patients paid on average almost $800 in out-of-pocket costs for their care in the first month. So this is at 28 days. That's a lot of money. That's a lot of money, you know, to plan for when a cancer diagnosis comes out of you from nowhere. You know, the vast majority of cancer patients are not, you know, don't have genetic mutations where they might have really high risks and they anticipate something. But most people are just living their lives, you know, saving up for retirement, saving up for their kids' college, and suddenly this hits you, and it's a lot of money. This study was done in our own province by the group at Quebec City, and they showed that while out-of-pocket costs may be manageable for most breast cancer patients, lost wages constitute a much greater burden. So on average, breast cancer patients in Quebec spent about 1,000 Canadian dollars in annual, so per year, out-of-patient costs, which seems manageable, fine. Maybe not for everyone, but for a lot of people in Quebec, I would think $1,000 a year is manageable. But if you look at the orange bar, that's the lost wages, and they found that the net losses were 27% of annual income because of time off work, and that's where that's where the money is, pun intended, for Canadian financial toxicity. It makes sense because really the provincial plans try to mitigate out-of-pocket costs. You know, it's really supposed to be no payment at the point of care, but you know, people still need to take time off work. Cancer is a chronic illness. And when they did their multivariate analyses, these losses were associated with higher levels of education, which makes sense because those patients probably had higher paying jobs to begin with, greater distance from the hospital, which was stratified as greater than or less than 50 kilometers, and lower levels of social support, and also self or part-time employment. As you can see, there aren't very many studies, or in Canada, there are a couple of more that I have not covered. One of them from the same group in Quebec City looking at radiation-related financial toxicity in breast cancer patients, which again showed sort of manageable out-of-pocket costs. But you know, it's just starting here, financial toxicity. We have only just begun to look at the impact of financial toxicity on our cancer patients here in Canada. And already, as we have seen, we have convincing signals that this is indeed a problem in our universal healthcare system. So it seems that financial toxicity in Canada is more related to indirect rather than direct costs, which is expected. But you know, what strikes me is that there really is a dearth of evidence and data and research looking into cancer patient experiences with financial hardship and financial toxicity. One of the biggest things I have not talked about in this talk at all, because I do believe it really is a whole different talk on its own, is how financial toxicities are linked to racial and ethnic disparities. We have no studies in Canada looking at that, whereas there are quite a few studies looking at that in the US, which have already seen links between non-white race and ethnicity and financial toxicity. And so this is a big gap here. And we know that disparities exist just as much in Canada as they do in the US. You know, and the kicker for financial toxicity is one of the main solutions that I talked about is keeping lines of communication open, so having an open dialogue with patients. That is very culturally dependent. Not all cultures are open to having conversations about costs. In fact, in some cultures, it's also taboo, and you know, you don't make an ally of your patients if you approach it. So we don't really have a good idea of how race and ethnicity is linked to financial toxicity in Canada. So we have a healthcare system which is, you know, the pride and joy of Canada across the world for providing universal healthcare coverage. But our patients in this system that's supposed to provide us universal coverage, complete health insurance, our patients are showing us symptoms of underinsurance. So we need to really listen to them. We need to study it. And we also need to work towards mitigating financial toxicity for our patients. So at McGill, I have developed the Breast Outcomes Research Group along with Dr. Stephanie Wong. And my focus is on financial toxicity, and I have a few students working with me now, and we have started looking at breast cancer toxicity research in Canada, and we're working on a systematic review of that. And in the last decade, so 10 to 11 years, we found only about 6 studies. Which, you know, we're going to summarize systematically, but it really just shows you the gap. So we're going to baseline the problem. And then we're also conducting a prospective cross-sectional survey in breast cancer patients to see how they're experiencing financial toxicity. So the cost questionnaire, so the comprehensive score of financial toxicity questionnaire is a validated tool to assess financial toxicity that was developed in conjunction with the University of Chicago. We're going to link that questionnaire to a quality of life assessment, as well as develop a disparities database, and so a disparities questionnaire, which will eventually go into a disparities database, and look at the association between financial toxicity and race ethnic disparity, but also all sorts of other disparities, you know, refugee status, language, things like that, which I believe have an impact on how patients experience cost and how patients want to talk about it, or how comfortable they feel talking about it. Eventually, you know, I would like to quantify breast cancer related financial toxicity in Canada and related to breast cancer outcomes using national population level databases. and also looking at more granular data and doing a cross-sectional prospective survey looking at the objective or the direct out-of-pocket costs of patients for the breast cancer care pathways. And eventually, ultimately, the goal is to design interventions through potentially institutional financial navigators and screening tools. If we can really link the drivers of financial toxicity, the severity of financial toxicity with variables that we can then develop into a screening tool to reduce financial toxicity. So I would like to thank, I didn't put up a slide with their pictures. I saw the previous presenter did that, and that was a great idea. So I'd like to thank Erica Inney and Chloe Theriot and Julia Leonard, who are all McGill medical students who are working with me. And thank you very much for inviting me, and I'll take questions.
Sure, I'll begin. I have a question. So wonderful talk. I really didn't realize the financial toxicity was such a problem or a burden in our country. So this is news to me. I was just wondering, has a study ever been done to stratify the differences in financial toxicity with different types of cancers? And if so, would this help in the allocation of funds to these patients?
Yes, there have been studies looking at that. In fact, Dr. Longo's group at McMaster did a recent systematic review looking at all cancer patients in universal healthcare systems. I think he picked 8 or 10 of the largest high-income country universal healthcare systems, and he did stratify by type of cancer. Breast cancer, at least in Canada, I believe, I have to review the study, but from what I remember, breast cancer has one of the greatest financial toxicity components. I think part of that, this is just sort of speculation right now, but I think part of that has to do with radiation therapy treatments and immunologics and chemotherapy, like all other cancers, but really radiation therapy and travel costs related to that play a big part in Canadian financial toxicity.
Thank you.
Oh, quiet room. Do you think gender can also, sorry, I'm reading some of the comments and the questions in the chat, if that's okay, but there's a question that says, from Juliana, that says, do you think that gender can also add up to all of this? And yes, for sure. It has been linked with a greater experience of financial toxicity in the US. There's no study that has been done in Canada, but in the US, a female gender was found to be linked to greater levels of subjective financial toxicity, which, the status quo as it is, women tend to be more the sort of family caregivers and tend to worry about more, so I'm not surprised.
Shira, Julio here.
Hi, Julia.
Great seeing you and welcome back to Montreal.
Thank you very much.
Great presentation on a very relevant topic, of course. I wonder if you could talk a little bit about the impact of low value interventions, such as known evidence-based interventions on financial toxicity. In cancer care, do you think interventions that have no proven effect has a huge impact on the direct financial cost to patients?
Perhaps not in Canada, perhaps not direct pocket costs in Canada because these, value assessments and comparative effectiveness research is very much integrated, like in the NHS. Like our drugs are approved through a very, very strict, rigorous process, but 100% in the US. Patients' deductibles and co-pays keep going up. So your question as to direct costs, no. But in terms of indirect costs, I think there's room there, yes, to improve financial toxicity because patients need to take time off work to undergo treatments. And if a treatment, a prolonged treatment, longer course of radiation, for example, 4 to 6 weeks as opposed to 2 weeks, that's a huge difference in terms of being able to go back to work. And we know in Canada that indirect costs constitute a major component of financial toxicity. So I would say, yes, value-based research still has a role, maybe not in decreasing the direct costs. Value-based research decreases direct costs to the payer, so to the government, and in doing so indirectly also in terms of taxation and things like that, but certainly on an individual patient level to decrease their indirect costs, yes.
Thank you.
I think there's another question in the chat by Andrew.
I wonder about the table on slide 37. This is off topic, but while reducing cost of care without changing therapy, was it elaborated on whether or not there was a change in clinical outcomes? No, that was beyond the scope of that study. It was just a survey, a patient survey. They didn't follow those patients longitudinally. So no, but that study specifically was not looking at changing therapy. So they kept the same therapy, but they managed patients' financial toxicity through means such as, maybe giving them taxi vouchers and linking them up with financial navigators who could provide copay assistance, things like that. So I would imagine there was no difference in oncologic outcomes.
Yeah, that's a wonderful talk. Really nice, especially taking some of us from out of our comfort zones. Really nice, wonderful. So what sort of advice would you give the government, for example? Is there any light at the end of this tunnel?
Oh, I'm sure. Of course there is. I'm an optimist. I'm a surgeon. I'm an optimist. Yes. I think honestly, having mechanisms in place on a clinic level is the work needs to be done at the grassroots level. I think having financial navigators and just letting people know that it's okay to talk about financial problems. And, I learned with my patients. So my patients came to me and asked me, listen, I'm having trouble. I can't afford taking another taxi to come see you. Want me to come see you in another 2 weeks? And like through just talking, I was told, oh yeah, we can give patients taxi vouchers, no problem. I mean, that's like the simplest thing, and it's just not integrated into our clinics because nobody mentions costs. And especially in Canada, it's thought that people don't have any financial burden at all. So it's about, knowing what the resources are already, and maybe potentially on a government policy levels, if we can, provide some sort of funding for more vulnerable populations, refugee patients and things like that, then yes, but of course, I think there's hope.
Thank you. So if there are no further questions, please join me in thanking Dr. Prakash. The really wonderful talk. Thank you very much. And I wish you all the best in your future research.
Thank you very much. And congratulations, Dr. Mwale. Congratulations on the recent nomination.
Thank you very much. Thank you.
Appointment. Thanks.
Yeah. Thank you, everyone, for attending the meeting. Thank you. Bye.